Hi everyone. Now we're going to do a very important topic, and that is PIH. For any exams which you are appearing for, whether you are an undergraduate student or student who's going to appear for NEET, NEXT, INI set or FMG, this is one of the most important topics which you have to do in obstetrics. Now, PIH, if you have done from edition 5, I would recommend you to do it again from edition 6, because there are a lot many changes which have come in edition 6, and whatever I'm going to teach you now is based on Williams 26th edition. So all the updates of William 26th edition have been included in this video. If you need, one thing I always feel that always textbooks are better than reading notes. And if there is one chapter which I would recommend you to read from Williams OBS, that would be, and that too from the 26th edition, it should be pregnancy-induced hypertension, right? Now, in PIH, in this particular video, I'm going to talk to you about the different terminologies, the pathogenesis, risk factors, predictors, and prevention of PIH. In PIH, Part 2, I'm going to talk to you about management. PIH is so important that in NEET PG 2022, there were 2 questions which were asked on PIH, one on magnesium sulfate and the other on pathogenesis of PIH. In INI CT as well, there was a question on PIH. So 1 or 2 questions you should expect from PIH in any exam which you are appearing for. Right? So first, before we talk to you about pregnancy-induced hypertension, first let us see how is hypertension defined in pregnancy. Hypertension in pregnancy means whenever a pregnant female's BP is more than equal to 140/90 on 2 occasions at least 4 hours apart. I'm sure you know about the white coat hypertension. So if a pregnant female comes to me and I see that her BP is more than equal to 140/90, immediately on basis of one reading, I'm not going to label her as a case of hypertension in pregnancy, right? I am going to first repeat the reading after 4 hours, and if her levels are BP is persistently increased to more than 140/90, then I'm going to say that yes, this pregnant female is hypertensive. A second very important concept which you need to remember is that it is not necessary that both systolic and diastolic should be more than 140/90 to call it as hypertension. If either systolic is more than 140 and diastolic, or diastolic is more than 90, or both are more, then also you are going to call it as hypertension, right? So either one, if it is raised, for example, suppose there is a female in whom when I measured her BP, it came out to be 144/84. And then on repeated measurements, I saw that her systolic BP is persistently raised to more than 140, but her diastolic BP is less than 90. Still, I am going to consider her as a case of hypertension, right? Now, this is something which you have to remember, a very, very important practical point and a applied question as well. Suppose if a pregnant female's BP is more than equal to 160/110, then in that case, you are not going to wait for 4 hours to repeat the BP measurement. In that case, you have to repeat the BP within 15 to 30 minutes, because in this case, you have to administer antihypertensive, and antihypertensive should be given between 30 to 60 minutes, right? Ideally, it should be given as soon as possible, but at least within half an hour to 1 hour of making a diagnosis of hypertension where the BP is more than 160/110, you have to give antihypertensive. So suppose if the question says that there is a pregnant female in whom BP was 160/114, what is the next step? Next step is that you have to repeat the BP within 15 to 30 minutes. You are not going to say that I'm going to repeat her BP after 4 hours. Neither you are going to say that based on one reading, I'm going to start her antihypertensives. No, you will have to repeat her BP, but then that has to be repeated quickly. You are not going to wait for 4 hours to repeat her BP. Now, a very important point which is needed for undergraduate student is that whenever you are going to present a case of PIH, your examiner can ask you what is the correct method for measuring BP. So then the important things which you have to remember while you are measuring BP of a pregnant female is, or rather this first point which I'm going to tell you, this is for whether you are taking BP of a non-pregnant female, pregnant female or of a male. You have to remember that whenever BP measurement has to be done, you have to make sure that the patient did not have any tea or coffee within 30 minutes of the BP measurement. That's one thing. Number two, always, BP should not be measured immediately after after the patient has entered into your OPD, because the patient was walking. Maybe he had climbed or he or she had climbed some stairs. So you should ask them to rest for 5 minutes and then you should measure the BP. Correct posture for measuring BP is either in a sitting position or in a semi-reclining position with back supported. Now, when a female or a male, in whichever case you are measuring BP, they are sitting, make sure that the legs are not crossed, their feet are on the ground, and arm is supported at the heart level. It is always important that BP should be measured in the left arm, and if patient cannot sit, then in that case you should measure the BP in left lateral position. This is for a pregnant female. Always use appropriate size cuff for measuring BP. Now, how do you say that it is an appropriate size cuff? Please remember, if the upper arm circumference, if it is less than 44 centimeters, then yes, you can use an arm cuff only. But in those obese females where the upper arm circumference is more than equal to 45 centimeters, in that case, you should not be using an arm cuff, but you should be using a thigh cuff to measure their BP. How do I come to know that the cuff is appropriately placed? Whenever the cuff will be appropriately placed, the width of the cuff will be equal to 40% of the circumference and it should cover 80% of the area from elbow to shoulder. Right? So these are important practical points which you have to remember when you are measuring the BP. So what is the gold standard method for measuring the BP? The gold standard method till now, the device was that a mercury calibrated sphygmomanometer should be used for measuring the BP. But recently, even the automated devices have been approved for measuring BP. And for measuring BP, the standard thing is in a pregnant female that systolic BP should correspond to Korotokov sound 1 and diastolic BP should be corresponding to Korotokov sound 5, that is the disappearance of the sounds. Please remember that normally in a non-pregnant female or male, it is the Korotokov sound 4 which is taken for measuring the diastolic BP, that is muffling of the sounds. But in a pregnant female, it is the Korotokov sound 5 which corresponds to the diastolic BP and not Korotokov sound 4. Now, earlier, a very important concept was that if systolic BP increased by more than equal to 30 millimeters of mercury, or if diastolic increased by more than equal to 15 millimeters of mercury at mid-pregnancy level, we then also said that the pregnant female has hypertension, even though the absolute value could have been less than 140/90. But now this criteria is no longer used. Now, what you have to understand is, first concept, they were saying that you should measure the systolic BP at mid-pregnancy level, and if the BP increased to more than equal to 30 millimeters of mercury, or if diastolic increased to more than equal to 15 millimeters of mercury, we should use it as a criteria for defining hypertension in pregnancy. My question to you is, why at the mid-pregnancy level? Why was this criteria used that in mid-pregnancy, if the levels of systolic BP are more than 30 or diastolic more than 15? This was because, if you remember the physiological changes during pregnancy, I told you that always the blood pressure decreases during pregnancy, right? And the decrease is maximum in second trimester, which means that normally in a pregnant female, systolic and diastolic BP should decrease in mid-pregnancy. But suppose instead of decreasing, the systolic and diastolic are increasing in mid-pregnancy, then it was used as a criteria for defining hypertension in pregnancy. Right? But this criteria is no longer used. The important thing which you have to remember is, in this category of females, although we are not going to say that they are hypertensive, still we are going to do surveillance in these females, because sometimes in this category of females where the BP increases by, systolic BP increases by 30 millimeters or more and diastolic by 15 millimeters or more, even though The absolute value may be less than 140/90. There are chances of them throwing seizures, right? That is why we are going to do a BP surveillance in these females. Another concept which you have to remember is that of delta hypertension. The concept of delta hypertension says that mean arterial pressure rises suddenly in a pregnant female, although it remains within the normal range. Then that is what is called as delta hypertension, right? So, have you understood? In delta hypertension, the mean arterial pressure is increasing, but it suddenly increasing, but it is remaining within the normal range. That is what is delta hypertension. Now comes, how does ACOG classify hypertensive disorders in pregnancy? So I have found out that yes, the pregnant female's BP is more than equal to 140/90. Now, how am I going to classify hypertensive disorders in pregnancy? ACOG says that the hypertensive disorders in pregnancy, they should be classified into 4 categories. Number 1 category is the pre-eclampsia syndrome, right? That is one category. Second category is gestational hypertension. Third category is chronic hypertension in pregnancy. And the fourth category is chronic hypertension with superimposed pre-eclampsia. Right, so these are 4 categories into which we are going to classify the hypertensive disorders during pregnancy. So, how am I going to do screening for hypertension? So, in all pregnant females, in each trimester, I am going to do 2 things to see whether they are developing hypertension or not. Number 1, I am going to do their BP measurement. And number 2, I am going to measure proteinuria by dipstick method. Why we are measuring proteinuria by dipstick method, I'll tell you a little later. But please understand that screening for hypertension is done by both these methods, wherein you are going to measure her BP in each antenatal visit, and also in each antenatal visit, you are going to do a urine dipstick method. Right, so proteinuria by the dipstick method. Now, suppose I have measured BP of a pregnant female and her BP has come out to be more than equal to 140/90 on 2 occasions 4 hour apart. Then I'm going to say, yes, my patient has got hypertension. And please remember, whenever BP comes more than equal to 140/90, you always have to check the proteinuria levels. Right? So, in all pregnant females in whom BP is more than equal to 140/90, you have to check their proteinuria levels. Now, once I see that the patient's BP is more than equal to 140/90, in order to classify them, I should check on what is the gestational age of the patient. Right? So, if gestational age, that is the period of gestation, is less than 20 weeks and her BP is more than equal to 140/90, in that case, I'm going to call her as a case of chronic hypertension in pregnancy. Chronic hypertension in pregnancy means that there was a hypertensive female who has conceived. In this case, in chronic hypertension, the patient's BP was raised before she conceived. It is raised during her conception, that is throughout pregnancy her BP will be raised, and even after delivery her BP would remain high. That means her BP will not come back to normal after 12 weeks of delivery. Right? So, whenever you have a pregnant female whose BP is increased by more than equal to 140/90, recheck her BP and also simultaneously do her proteinuria levels. If on rechecking her BP is still high, then the next thing which you should do is, whether you are solving a question on hypertensive disorders or whether you are sitting in your OPD, you should check the period of gestation. If period of gestation is less than 20 weeks when hypertension has developed, then that means you are dealing with the case of chronic hypertension in pregnancy. This means this was a hypertensive female who has conceived, and you can ask her also to confirm that, are you a known case of hypertension? Sometimes the pregnant female might be knowing that yes, she was a known case of hypertension. Sometimes they may not be knowing, right? So in that case, what I'm going to do is, if the period of gestation is less than 20 weeks, I'll classify as a case of chronic hypertension in pregnancy. A characteristic feature of chronic hypertension in pregnancy is that the BP will not come come back to normal 12 weeks after delivery. On the other hand, if I see that the period of gestation is more than equal to 20 weeks when first time the increase in BP has been noticed, then I am going to call her as a case of pregnancy-induced hypertension. Again, in pregnancy-induced hypertension, there are two characteristics. Number one, the increase in BP will be seen after 20 weeks of pregnancy, and number two, BP will come back to normal within 12 weeks of delivery. Now, once I know I am dealing with pregnancy-induced hypertension, the next thing which I have to check is the proteinuria. As I told you, whenever BP is more than 140/90, always you have to check proteinuria by dipstick method. And if I see that, yes, proteinuria by dipstick method is more than equal to +1, right? Then in that case, I am going to see proteinuria by dipstick method is just a screening test, right? So whenever proteinuria comes more than equal to +1, then you should follow it up with 24 hours protein excretion. And if 24 hours protein excretion is more than equal to 300 milligrams in 24 hours, or you can do a urine protein is to creatinine ratio, which if it is equal to more than equal to 0.3, then I'm going to call her as a case of preeclampsia. So in patients of preeclampsia, there is PIH, and this along with PIH, there is proteinuria, which by dipstick method should be more than equal to +1, or by in 24 hours urine sample, the proteinuria should be more than equal to 300 milligrams, or the serum protein is to creatinine ratio should be more than equal to 0.3. Clear? Now, suppose when I did dipstick proteinuria on dipstick method, and I found out that the proteinuria is in traces or proteinuria is absent, then in that case, I'm going to do investigations to look at the signs of end organ damage. What are the signs of end organ damage? I'll tell you shortly. So after proteinuria comes out to be negative or in traces, now I am going to do all the blood tests to see whether end organ damage has happened or not. Now, if end organ damage is present, even though proteinuria was absent, still I am going to classify her as a case of preeclampsia. But if signs of end organ damage are absent and proteinuria was also absent, that is why I did the signs of I checked for the signs of end organ damage, I'm going to call her as a case of gestational hypertension. Please understand that both preeclampsia and gestational hypertension are varieties of pregnancy-induced hypertension, right? So what is the difference between them? And what is their general characteristics, their common characteristics? Because preeclampsia and gestational hypertension both are varieties of PIH. So in both of them, the increase in BP is going to happen at more than 20 weeks of gestation. And in both of them, BP comes back to normal within 12 weeks of delivery. The difference is that in preeclampsia, proteinuria could be present or signs of end organ damage would be present. So either proteinuria would be present or signs of end organ damage would be present. It is not necessary that proteinuria should be present. Then only we say that we are dealing with a case of preeclampsia. If proteinuria is absent but signs of end organ damage are present, still we say that we are dealing with a case of preeclampsia. Now, if there is no proteinuria and there are no signs of end organ damage, then we say we are dealing with a case of gestational hypertension. So I'm sure by now you've understood three terminologies. You've understood chronic hypertension, you've understood pregnancy-induced hypertension, which further is classified into preeclampsia and into gestational hypertension, right? Now let's talk little bit about proteinuria and signs of end organ damage. You know, many questions are asked on PIH. So PIH has to be done in detail. Do not take shortcuts for PIH. Whatever I am teaching you in PIH, you have to remember that. Apart from that, if possible, read Williams' 26th edition on PIH. On preeclampsia, there are 3 chapters. One is preeclampsia, eclampsia syndrome. The other one is management of preeclampsia. And the third one is chronic hypertension. Right? Now coming to proteinuria. Now the screening method for proteinuria is dipstick method, and by dipstick method, if proteinuria is more than equal to +1. Remember, just one thing which I want you to note, that ACOG recommended that dipstick method more than equal to +2 should be taken as proteinuria. But please remember, Williams Orb's 26th edition, page 689 says that this recommendation has not yet been approved, and still we are taking dipstick more than equal to +1, persistently more than equal to +1 as a criteria for diagnosing preeclampsia, right? So although in edition 5 I told you that the criteria has been upgraded and it has become +2, but remember that Williams edition 26 says that no, this has not yet been the criteria has not yet been updated. Still it is more than equal to +1, right? Now, this is just a screening method. If you get that dipstick method proteinuria is more than equal to +1, the moment you see this, then you should go for the gold standard method, and the gold standard method is 24 hours urine collection. And in 24 hours urine collection, if you see that the protein excretion is more than equal to 0.3 grams or more than equal to 300 milligrams, then you say that yes, proteinuria is present. If you are not going for 24 hours urine collection, then in that case, you can look at the urine protein is to creatinine ratio, which if it is equal to more than equal to 0.3, then you say that yes, proteinuria is present. Now, the type of proteinuria which you get in preeclampsia is a non-selective proteinuria. And why is proteinuria happening? It is happening because of increased tubular permeability. Right? Now, this proteinuria is not associated with excretion of any red cell casts. That means it is not associated with nephritis, neither it is associated with any nephrotic syndrome. The urinary segment in preeclampsia is going to show you only granular cast. You will never get wax casts. You will never get red cell casts in case of preeclampsia. Whatever urinary segment you are going to analyze, and if you see under microscopy, you are going to get only granular casts, which could be fine, which could be coarse. Right? Please remember that if you are getting red cell casts or if you are getting features of nephrotic syndrome, it points towards chronic hypertension with underlying renal disease as a problem. Right? It does not mean that we are dealing with preeclampsia or PIH. Clear? Okay. Now, what are the signs of end organ damage? For signs of end organ damage, any one of the following should be present to say that it is a sign of end organ damage. Number 1, platelet count less than 1 lakh. Number 2, creatinine more than equal to 1.1 milligrams per dl or doubling from the baseline. Number 3, liver enzymes twice their normal value plus epigastric pain, headache or visual disturbances, and pulmonary edema. So, any of these, if it is present, it indicates that it is a sign of end organ damage. And as I told you, preeclampsia means that either you are getting proteinuria or you are getting signs of end organ damage. Now, preeclampsia can be classified by 2 methods. One is based on the onset. You can classify preeclampsia as early onset preeclampsia, when preeclampsia is going to happen after 20 weeks and up till 34 weeks. Or you can classify is at late preeclampsia, when it is happening after 34 weeks and up till 37 weeks. Or you can classify it as a term onset. Term onset means that preeclampsia is happening at more than equal to 37 weeks, right? So early preeclampsia, late preeclampsia, or term preeclampsia. But a better way of classifying preeclampsia is based on its severity, whether severe features are present or whether severe features are absent. So preeclampsia without severe features, which was earlier called as mild preeclampsia, the term mild preeclampsia is no longer used, and preeclampsia with severe features, which was earlier called as severe preeclampsia. Right? Now, how do you differentiate between mild and severe preeclampsia? Or preeclampsia without severe features and preeclampsia with severe features? Again, this table is very, very important because there are few new things which have come in the table. Number 1 is the BP criteria. If BP is more than equal to 140 by 90 but less than 160 by 110, then you call it as preeclampsia without severe features. But if on the other hand, BP is more than equal to 160 by 110, then you call it as preeclampsia with severe features. Now, whenever there is preeclampsia with severe features, there are increased chances of eclampsia. right? And there were certain signs which earlier were called as signs of impending eclampsia. And as I told you just now, that in females who have preeclampsia with severe features, the chances of eclampsia are there. So all those symptoms which were coming in under symptoms of impending eclampsia, if they are present, it means that it is preeclampsia with severe features. Are you understanding? Eclampsia is a consequence or of severe preeclampsia, that is preeclampsia with severe features, right? So if earlier we used to say that there are certain symptoms which tell us that in a patient of severe preeclampsia, eclampsia is about to happen, which were called as symptoms of impending eclampsia. So now they say that if you are getting symptoms of impending eclampsia, it automatically means you are dealing with preeclampsia with severe features. So what were those features? Number one, headache. Not any kind of headache. Headache which is not being relieved by analgesic. Then severe epigastric pain and visual symptoms. So if there is a patient of preeclampsia who has headache, who has epigastric pain or visual symptoms, we are automatically going to say that they are preeclampsia. This is a case of preeclampsia with severe features. Similarly, if a patient throws convulsions, now, if a patient throws convulsions, we call it as eclampsia. And as I told you, that again, eclampsia is a sequelae of severe preeclampsia. So, if convulsions are present, it indicates that we were dealing with preeclampsia with severe features, although it has been given a different name, eclampsia. But then that means that you were dealing with a case of preeclampsia with severe features. Then signs of end organ damage. If signs of end organ damage are present, you classify it as preeclampsia with severe features. So number one criteria for differentiating between preeclampsia with severe features and without severe features is the BP criteria. Number two are those symptoms, ominous symptoms which tell you that eclampsia might happen. So all these three symptoms, visual disturbances, severe headache, severe epigastric pain, tell you automatically that you are dealing with the case of preeclampsia with severe features. Then if signs of end organ damage are present, they indicate severe preeclampsia. Or if you are getting convulsions, it means that you are dealing with a case of eclampsia, and which means that you were dealing with a case of severe preeclampsia. So it's a retrograde thing. If convulsions happens, then I come to know retrograde that yes, I was dealing with a case of severe preeclampsia. All right? But please remember, if convulsions happen, you are going to call it as eclampsia. Retrogradely, you are going to say that yes, that was a case of severe preeclampsia. And if I would have given her a drug to protect convulsions, she wouldn't have got convulsions, right? Now, the important concepts are that the following are removed by ACOG as a criteria to diagnose preeclampsia with severe features, and this is number one, oliguria. Oliguria is no longer a criteria to say that you are dealing with a case of severe preeclampsia or preeclampsia without severe features. Number two, IUGR, and number three, proteinuria. Proteinuria quantification. So earlier they used to say that if proteinuria is more, then that means you are dealing with preeclampsia with severe features, and if proteinuria is less, you are dealing with preeclampsia without severe features. But these three criteria, oliguria, IUGR and proteinuria quantification, that means increased proteinuria, they are no longer a criteria to differentiate between severe preeclampsia and mild preeclampsia, although all these are findings in a case of preeclampsia with severe features, but they are not included in diagnostic criteria, right? In the diagnostic criteria, we are including BP, which is very, very important. In the diagnostic criteria, we are including signs of end organ damage, and we are including three symptoms: headache, epigastric pain, and visual symptoms, to distinguish between preeclampsia without severe features and preeclampsia with severe features, right? Then, Another very important thing is that suppose you are dealing with a pregnant female in whom earlier proteinuria was absent and her BP increased after 20 weeks of pregnancy. Now, because her BP increased after 20 weeks of pregnancy and there wasn't any proteinuria, you classified her as a case of gestational hypertension. Now, this patient of gestational hypertension over a period of time develops proteinuria. In that case, you are going to upgrade the diagnosis to preeclampsia. Right? So the moment a patient of gestational hypertension develops proteinuria, you are going to say that I am dealing with a case of preeclampsia. You are not going to say that I'm dealing with a case of gestational hypertension. So as far as gestational hypertension is concerned, it is a provisional diagnosis. Why? Because as the disease progresses, it may get reclassified into preeclampsia. And I told you, how are you going to reclassify it into preeclampsia? If you start getting proteinuria or signs of end organ damage, then you classify it as a case of preeclampsia. Please remember that in a patient of gestational hypertension, suppose patient doesn't develop proteinuria, but patient BPs become more than equal to 160 by 110, right? Or so whenever a gestational hypertension patient's BP becomes more than equal to 160 by 110, even though she might not have developed proteinuria, still you are going to classify her or call her as a case of preeclampsia with severe features, and management will be like preeclampsia with severe features. Are you understanding this? Patient develops gestational hypertension, patient develops proteinuria or signs of end organ damage, definitely I'm going to put her in a case of preeclampsia. But if, patient doesn't develop a gestational hypertension, patient doesn't develop any proteinuria, she doesn't develop any signs of end organ damage, but her BP becomes more than 160 by 110, then again I'm going to reclassify her and I'm going to call her as a case of preeclampsia with severe features, and I'm going to treat her in the same manner as I treat preeclampsia with severe features. This is because sooner or later they will develop proteinuria, or sooner or later they are going to have other features of preeclampsia, right? The third thing, after these gestational hypertension patients have delivered, you are going to measure their BP after 12 weeks. Now, after 12 weeks, see, in gestational hypertension, ideally, BP should come back to normal within 12 weeks of delivery. But if it is a gestational hypertension patient in whom BP is persistently raised even after 12 weeks of delivery, then this means you were not dealing with gestational hypertension. This means you were dealing with chronic hypertension. So the diagnosis of gestational hypertension will be changed to chronic hypertension. But after 12 weeks of pregnancy, if you see that the BP has come back to normal, then I will call it as transient hypertension. So the term gestational hypertension is a very, very provisional diagnosis. This gestational hypertension terminology can upgrade to preeclampsia. It can upgrade to severe preeclampsia. It can be upgraded to chronic hypertension, or you may call it as transient hypertension after delivery. The term transient hypertension means that yes, you were dealing with gestational hypertension, and since it is transient in nature, you rather than calling it as gestational hypertension, you start calling it as transient hypertension after delivery, right? Have you understood? Okay. Now, although the pathological changes which are seen with preeclampsia, they are not seen in cases of gestational hypertension, but then 25 to 50% patients of gestational hypertension, they progress to preeclampsia. That is why in patients of gestational hypertension, maternal and fetal monitoring is mandatory. Clear? Now, what is eclampsia? As I told you, eclampsia means occurrence of new onset generalized tonic-clonic seizures or coma in a woman with preeclampsia. It is the most severe form of preeclampsia spectrum. Now, eclampsia can happen during pregnancy when it will be called as antepartum eclampsia, which is the most common type of eclampsia, and it is the one which has got the best prognosis. Or it can be intrapartum, that means when the convulsions are thrown for the first time during labor, or it can be postpartum, which means that the first time the convulsions are happening within 48 hours of delivery. Now, if convulsions are not happening within 48 hours of delivery, but they are happening after 48 hours of delivery, then first rule out other causes for convulsions and then say I am dealing with a case of eclampsia. If it is happening within 48 hours of delivery, then you can say that yes, you are dealing with eclampsia. But if the first time convulsions are happening after 48 hours, then you should definitely rule out other causes of convulsions before calling it as a case of postpartum eclampsia, right? Coming to the last terminology which you should know, that is chronic hypertension with superimposed preeclampsia. Now, chronic hypertension definitely means that it is a hypertensive female who has conceived, and that means the increase in BP would be seen before 20 weeks of pregnancy. Now, in such a patient of chronic hypertension, if suddenly at 20 weeks her BP becomes uncontrollable, or suddenly at 20 weeks she develops new onset proteinuria, or suddenly she develops signs of end organ damage. If any of these three things develop in a chronic hypertensive patient, then you say it is chronic hypertension with superimposed preeclampsia. Clear? So these were the different terminologies which are used for classifying hypertension in pregnancy. Now comes pathogenesis of PIH or preeclampsia. Please remember, this is the most important part of the lecture. Rather, I would say entire PIH is very important, but then pathogenesis, a detailed knowledge about pathogenesis is important, because these days many MCQs are directed on the pathogenesis of PIH. Now, before I tell you about the pathogenesis of PIH, in normal pregnancy, if you remember, I told you that in the placenta, there will be villi and there will be the intervillus space. Now, in this intervillus space, which has got maternal blood, the spiral arteries are going to open and they are going to fill this intervillus space with maternal blood. What happens is that the cytotrophoblast, which cytotrophoblast? The extravillus cytotrophoblast. And not just the extravillus cytotrophoblast, specifically the endovascular trophoblast. So remember that it is the endovascular cytotrophoblast which is a part of extravillus cytotrophoblast, which replaces the lining of these maternal spiral arteries. Why is the endovascular cytotrophoblast doing that? This is because these spiral arteries, they have got very high resistance. So in order to convert them from high resistance vessels to low resistance vessels, this is happening. Why do we want to convert these spiral arteries into low resistance vessels? So in order to understand that, I hope you remember your laws which you did in class 12 in physics. One of the law was that pressure and volume are inversely related, which means that if the pressure is high, the volume of blood which is coming to the intervillus space will be less. But if pressure is low, the volume of blood which is coming to the intervillus space will be high. It will be more, right? So what cytotrophoblast is doing, it is converting these spiral arteries from high resistance vessels to low resistance vessels so that more volume of blood can enter into the intervillus space, right? And this is going to ensure that yes, a proper blood supply is going to the fetus. Now, this is what is called as vascular remodeling. Have you understood what is vascular remodeling? Now, this vascular remodeling, it never happens in one step. This vascular remodeling, it happens in two steps. The first phase is completed by 12 weeks and then second phase is completed by 18 to 20 weeks. Now, many questions are asked on this vascular remodeling, and if they ask you that in which is the cytotrophoblast which is responsible for vascular remodeling, please remember that the best answer is endovascular trophoblast or cytotrophoblast. And if endovascular cytotrophoblast is not given in the options, then it is the extravillus cytotrophoblast, which is the second best answer. Now, during this vascular remodeling, The endovascular trophoblast, it alters its molecular expression from epithelial cells to that of endothelial cells. So from epithelial cells, it is going to alter its expression and it is going to become endothelial cell. And this altering of expression is called as pseudovasculogenesis. Right? Now, my next question is that who is regulating this vascular remodeling? A most important factor which helps in regulating the vascular remodeling is maternal natural killer cells. All these are very, very important questions. Now, what is going to happen? This is what was happening normally. Normally there is, vascular remodeling which is being regulated by maternal natural killer cells, and it is being done by the endovascular trophoblast in 2 phases, and there is pseudovasculogenesis during this process. Have you understood vascular remodeling? Now understand what happens in patients of PIH. Now, in patients of PIH, there is defective vasculogenesis, but it is not just defective vasculogenesis which is playing a part. It is an entire spectrum which is going to happen, and this entire spectrum of events which are going to happen, they are divided into 2 phases. Right? So the New Williams says that whatever is happening in patients of PIH or preeclampsia, it can be divided into 2 stages or 2 phases. The first stage or first phase is called as the placental syndrome. And the second phase or the second stage is called as the maternal syndrome. Now, what is happening in the placental syndrome? In placental syndrome, there will be abnormal vascular remodeling. Now, when I say abnormal vascular remodeling, what do I mean? So, let me show you an image to make it more clear. See, over here, this is the spiral artery of a non-pregnant female. This over here is what is seen in normal pregnancy. In normal pregnancy, the cytotrophoblast is replacing the lining of the spiral arteries and converting it into dilated vessels. Now, what happens in PIH? In PIH, this vascular remodeling is going to happen partially. It is not happening completely. So, a part of the vessels are becoming dilated, but rest of them, they remain tortuous and the resistance remains high in the rest of the vessels. Now, what is the landmark? Till where is this vascular remodeling happening? So, see, if you look at a spiral artery, it is the one which is going in the decidua also and in the myometrium also. Now, in a normal pregnancy, the cytotrophoblast will replace the lining of the spiral artery in the decidual segment as well as the myometrial segment. But in case of PIH, the vascular remodeling is limited only to the decidual segment. The myometrial segment, the remodeling doesn't happen. So what happens in case of PIH? In case of PIH, the cytotrophoblastic cells, they infiltrate the decidual part of the spiral arteries, but they fail to penetrate the myometrial segment. So spiral arteries, they fail to develop into large tortuous vascular channels and they remain narrow. Now, because spiral arteries are remaining narrow, so the amount of blood which is entering into the intervillous space will be less, and that is going to lead to placental hypoperfusion and placental ischemia, right? This is what is called as placental syndrome. Have you understood this? Yes. So what is happening in placental syndrome? There is abnormal vascular remodeling, which is involving only the decidual part of the spiral arteries and not the myometrial part of the spiral artery. Now look at the question which was asked in NEET PG 2022. A pregnant female with no other comorbid condition develops preeclampsia. She asks as to why she has developed the condition, and the doctor explains that it is due to option A, failure of invasion of the spiral arteries by villus trophoblast. So is it the villus trophoblast which is going to invade the spiral arteries? No. Failure of invasion of radial artery by cytotrophoblast? No. Failure of invasion of spiral artery by extravillus trophoblast? Yes. Failure of invasion of arcuate artery by extravillous trophoblast? No. So it is failure of invasion of the spiral arteries by the extravillous trophoblast. And to make the question a little more tougher, they could have also given you endovascular trophoblast. Have you understood the placental syndrome? Yes. Now, in the placental syndrome, yes, one major part was abnormal vascular remodeling. But then the placental syndrome is not just because of abnormal vascular remodeling. There are other contributors to the placental syndrome also. And what are the other contributors? Number 2, abnormal placentation. So because of abnormal placentation, also there is placental syndrome. And because of impaired trophoblastic differentiation, that is impaired pseudovasculogenesis. So as I told you, pseudovasculogenesis happens, but if there is impaired pseudovasculogenesis, then also it can lead to placental syndrome. Please remember, this abnormal, trophoblastic differentiation, that is impaired pseudovasculogenesis, it mainly happens due to a protein which is called as semaphorin 3 protein. And it is the semaphorin 3 protein which is increased in a pregnant female with PIH. So all these 3 factors, abnormal vascular remodeling, abnormal placentation, and abnormal pseudovasculogenesis, they lead to placental hypoperfusion, hypoxia, or ischemia. And because of placental hypoperfusion comes the next stage, or the stage 2, and that stage 2 is maternal syndrome. Right? So now we are going to look at what is going to happen because of this placental ischemia. How is maternal syndrome going to happen? How is the mother affected because of this placental ischemia? First, understand that this placental ischemia is going to lead not only to problems in the mother, but definitely it is going to lead to problems in fetus, and the size of the placenta is also going to become small because of the placental ischemia. That is why in patients of pregnancy-induced hypertension or in uteroplacental insufficiency, we have a small-sized placenta. Now, how is this placental ischemia going to affect the fetus? See, how it affects the mother is a long discussion. So that I have to tell you in continuity. So that is why first I'm going to tell you how this placental ischemia affects the fetus, and then I'm going to go to the maternal syndrome. Now, placental ischemia in the fetus, it leads to IUGR. Obviously, common sense tells me that if the placenta is receiving less blood and there is placental ischemia, the amount of blood which is going to the fetus is going to decrease, right? And if the amount of blood which is going to the fetus is going to decrease, the growth of the fetus will be decreased, and that is going to lead to IUGR. Number 2, because the amount of blood which is coming to the fetus is decreased, so obviously the amount of blood which is going to the fetal kidney is going to decrease, and because renal blood flow in the fetus is going to decrease, so GFR is going to decrease, and now this fetus is going to produce less urine. There will be oliguria, and because of oliguria there will be oligohydramnios. That is why in patients of PIH, there are chances of IUGR and there is oligohydramnios. So have you understood how placental ischemia affects the fetus? Now let us see how this placental ischemia is going to lead to maternal syndrome. Now, whenever there is placental ischemia, the placenta is going to release the following, into the maternal circulation. What it does is, whenever there will be placental ischemia, vasodilators are going to decrease. Vasoconstrictors are going to increase. So what placenta is going to do, this placenta, this angry placenta that mother had sent me, how dare mother's spiral arteries give me less blood, right? So this placenta is now going to take a revenge, and it is going to send some mediators into the mother's circulation. And these mediators will be the ones which lead to vasoconstriction. So all the mediators which lead to vasoconstriction increase in PIH, and all the mediators which lead to vasodilatation, they decrease in PIH. So this angry placenta is going to increase SFLT1, it is going to release soluble FMS like tyrosine kinase 1 into the mother's circulation, and it is going to release endoglin, serum endoglin into mother's circulation. Now, I want all of you that if you are maintaining a 20th notebook, in the 20th notebook, one chart which you should make is all those mediators which increase in PIH and all those mediators which decrease in PIH. Many times these questions have been asked and you tend to get confused. Also, the second thing which you should include in in the 20th notebook is risk factors for PIH. Risk factors for PIH, questions are asked on the risk factors itself. So you should know what are the risk factors for PIH. And third thing which you should include on that notebook from this particular video is the conditions where aspirin is given to a pregnant female to prevent PIH. All this is going to come later in this video. So these are the three very, very important things which you should note in your 20th notebook from PIH. Right? So what has placenta, the angry placenta done? The angry placenta has increased the vasoconstrictors. For example, it releases SFLT1 into mother's circulation and it releases endoglin into mother's circulation. It decreases vascular endothelial growth factor and it decreases placental growth factor. So it says, because you sent me less blood, I am going to make you suffer and I'm going to bring about vasoconstriction. So it increases vasoconstrictors and it decreases the vasodilators. Not only this, it is going to release inflammatory mediators like cytokines, interleukins, and TNF-alpha. Now, because of these inflammatory mediators, there is oxidative stress in the mother. And because of a combination of all these things, because of increased vasoconstrictors, decreased vasodilators, and oxidative stress, in mother, two things are going to happen. As I told you, number one, vasoconstriction is going to happen. Right? And because there will be vasoconstriction, so mother's BP will increase. So the first clinical manifestation of PIH, which occurs after 20 weeks of pregnancy, is increase in BP. But then not only it is going to lead only to vasoconstriction, because of the oxidative stress and because of vasoconstriction, there will be vascular endothelial injury in the mother. Now, whenever there is vascular endothelial injury in the mother also itself, this endothelium releases more of vasoconstrictors and less of vasodilators because of the vascular endothelial injury. So because of this vascular endothelial injury, what is going to happen? Prostacyclin, which is a vasodilator, and nitric oxide is going to decrease, and thromboxane A2 is going to increase. So in total, just now I have told you three things which are increasing in a patient with PIH. Number one, SFLT1 is increasing. Number two, endoglin is increasing. Number three, thromboxane A2 is increasing. What is decreasing? Prostacyclins are decreasing. Nitric oxide is decreasing. Vascular endothelial growth factor is decreasing. And placental growth factor is decreasing. Now, this was a question which was asked in INI set May 2022 exam, right? Now, as I told you, that because of this vascular endothelial injury, what has happened? Because of this vascular endothelial injury, from the endothelium also vasoconstrictors have increased and vasodilators have increased, which is going to lead to vasospasm, and that in itself is going to lead to ischemia, necrosis, and hemorrhage. Not only this, because of the endothelial cell dysfunction or endothelial injury, the capillaries are going to become leaky. So because of this vascular endothelial injury, there will be leaky capillaries. Now, what do you understand by leaky capillaries? Leaky capillaries means that there will be tiny holes which will be made in the capillaries. So imagine that there is a pipe from which water and sand is passing, and you have made small holes in those pipe, right? That is a situation similar to leaky capillaries. Now, because of those tiny holes which are made in the pipe, the water will come out, but the sand particles will remain inside. Same thing happens with this leaky capillaries. The plasma is going to come out, so there is going to be fluid which is going to accumulate in third space, and that leads to edema. But inside the capillaries, what is happening? Inside the capillaries, there will be hemoconcentration. So outside, the extravascular fluid is increasing, which is leading to edema, but inside the capillaries there is hemoconcentration. Now, because of this hemoconcentration, what is going to happen? Because of this hemoconcentration, there will be stasis of blood and platelets are going to get activated and aggregated. So because of endothelial cell injuries, the capillaries became leaky, and because the capillaries became leaky, there was hemoconcentration. This hemoconcentration leads to stasis of blood and it leads to platelet activation and aggregation. Now, before I move further, let us see a few important points over here. I am telling you in PIH there is hemoconcentration. Tell me normally what happens in a pregnant female in whom there is no PIH. I told you normally in a pregnant female, hemodilution happens. But what is happening in PIH? In PIH, there is hemoconcentration. So tell me, in a patient of PIH, if you want to decrease her BP, will you give her diuretics? No. What do diuretics do? Diuretics decrease the intravascular volume. And already the intravascular volume is decreased in a patient of PIH, right? Already there is hemoconcentration. So can I give diuretic in a patient of PIH? No, I cannot use diuretics in patient of PIH. Number 2, does this bring something to your mind? Does it ring bells that there is endothelial injury, there is stasis of blood, and there is hypercoagulation? What is all this? This all is Virchow's triad, right? And which you've studied in surgery. So because of this endothelial cell injury, stasis of blood and hypercoagulation, there are increased chances of thrombosis, and that is what is Virchow's triad. Next thing, if you remember, I told you that one of the signs of end organ damage was a decreased platelet count, thrombocytopenia. So now do you understand why there is thrombocytopenia in PIH? Because of platelet aggregation. Because of this platelet aggregation, there is thrombocytopenia which happens in patients of PIH. So the first hematological abnormality which you get in a patient of PIH is thrombocytopenia, right? Okay. Now, what is happening because of this increased chances of thrombosis? Now, because of the increased chances of thrombosis, there can be multiple organ failure or multiple organ dysfunction. So, PIH is a problem which has the capacity to involve multiple organs because of the tendency of thrombosis, right? Now, if it can involve multiple organs, and if I ask you what is the first or the most common organ which is involved in PIH, the first or the most common organ which is involved in PIH is maternal kidneys. In maternal kidneys, what are you going to get? Now, because in PIH, there is hemoconcentration, because of which the amount of blood flow to all the organs is going to decrease. Now, because the amount of blood flow to all the organs decreases, so amount of blood coming to the kidney will also decrease. So there will be decreased renal blood flow. And because there will be decreased renal blood flow, there will be decreased GFR. Decreased GFR means the filtering capacity of the kidney is decreasing, which means that now there will be increased serum creatinine and increased serum uric acid, and there will be oliguria. So mother is going to experience oliguria, fetus was experiencing oliguria, and in the mother you are going to get increased serum uric acid levels, increased serum creatinine levels. That is why I told you that one of the signs of end organ damage was serum creatinine more than equal to 1.1 milligrams per DL. Now, if they ask you what is the most characteristic histopathological lesion which is seen in PIH in the kidney, the most characteristic lesion is glomeruloendotheliosis. Glomeruloendotheliosis. I'm sure you know more about glomeruloendotheliosis than me. You've studied pathology much more than me. But what you have to basically remember is that in glomeruloendotheliosis, it is the endothelial cells which undergo dilatation and they are bloodless. Right? So there is the bloodless dilatation of the endothelial cells. That is what is glomeruloendotheliosis. right? Then, as I told you, all the organs will be affected. Liver will be affected. How liver will be affected? Just now I told you. Kidney, I told you how it is affected. Now let us see what are the hematological changes which you get in case of PIH. Number one, and the first hematological change is decreased platelet count. Apart from that, you are going to get microangiopathic hemolysis, intravascular coagulation, and LDH levels are going to increase. Right, so these are the hematological changes which you see in PIH. Then how is the liver involved? In liver, you are going to see that there will be stretching of the Gleason's capsule, and this stretching of the Gleason's capsule leads to epigastric pain or right upper quadrant pain. And if the pregnant female with PIH is getting a right upper quadrant pain or epigastric pain, then that indicates severe PIH, right? Then periportal hemorrhage and vasospasm is going to happen. Now, because of the periportal hemorrhage and vasospasm, liver enzymes are going to increase and there will be nausea and vomiting. There could be hematoma formation as well. So these are the changes which are going to happen in the liver when the liver is going to get involved. When retina is going to involve, again, you are going to get vasospasm, and that is one of the first change which you get on fundus examination in a patient of PIH. There will be visual changes. In visual changes, the first visual change which you get is a scotoma, right? Apart from that, you can get hypertensive retinopathy. I just need to tell you one thing about hypertensive retinopathy, and that is the classification is called as Keith and Wegener classification. Then there can be retinal detachment, which can lead to blindness. More about visual changes I'm going to talk to you when I'm going to talk to you about the fundus examination, that is in video 2. Over here, just remember Keith Wegener classification. Then remember that the first visual change is scotoma, and the first change which you get on fundus examination or ophthalmic examination is vasospasm, right? Now, so this means for everything which is happening, for the entire cascade of events, for all the organs which are getting involved, what is the main culprit? The main culprit is abnormal vascular remodeling. In other words, abnormal placenta. So it is this abnormal placenta which is responsible for this entire cascade of events. Right? So if I say it's this abnormal placenta which is responsible for PIH, there are two applied things which we can deduct from this statement. Number one, we can conclude that if it is this abnormal placenta which is responsible for this PIH, so if I remove this abnormal placenta, in other words, if I deliver the patient, I do a termination of pregnancy. Termination of pregnancy doesn't mean abortion. Termination of pregnancy here means induction of labor. So if I induce labor in patients of PIH, the placenta will be delivered out, and the moment placenta will be delivered out, and the entire cascade of event is going to reverse. So if I ask you that what is the definitive management of PIH, definitive management always is termination of pregnancy. In other words, induction of labor. Right? Now, the other thing which we understand is that for PIH to develop, is fetal tissue necessary? No. Fetal tissue is not necessary. What is necessary? I need only placental tissue. Right? This means that in molar pregnancy, for example, a complete mole. In a complete mole, there is no fetal tissue, but there is placental tissue. And it is this placental tissue that is the trophoblast, the cytotrophoblast, the extravillous cytotrophoblast, or the endovascular cytotrophoblast, basically, which is responsible for this PIH. Right? So as long as trophoblast and the cytotrophoblast are present, till that time, yes, a patient can develop PIH, irrespective of whether fetal tissue is present or not. And this is the reason why in molar pregnancies you get PIH. Have you understood this? Now, if you've understood this, then remember that what are the factors which are responsible for this absent or defective vascular remodeling? Why is this defective remodeling happening in a few females and not happening in a few females? There are basically three factors which are responsible for this abnormal vascular remodeling. Number one is the immunological factor. See, pregnant females with PIH, it is seen that they have increased immune response against paternal genes, right? So, all the pregnant females who have PIH, it is seen that they have increased immune response against paternal genes. Now, how did we come to this theory? We came to this theory because there are increased chances of PIH in a primigravida female. A primigravida female is getting exposed to the paternal genes for the first time, right? And that is why she has increased immune response against that paternal antigen, against those paternal genes. And that is why primigravida females are risk factors for PIH. Similarly, there are increased chances of PIH in a female who is pregnant from a new partner, right? Similarly, if inter-pregnancy interval increases, then also that becomes a risk factor for PIH, or females who were using barrier contraceptives. The females who were using barrier contraceptives were not exposed to paternal genes, and that is why they are also risk factors for PIH, or females who conceive through ART. Right? They are also at increased risk for having PIH. And in molar pregnancy, if you remember, in molar pregnancy, there are increased paternal genes. If we are talking about a partial mole is triploid and the extra genes are coming from the father. And if we are talking about a complete mole is diploid and the entire genes are coming from the father. Right? So that is why this theory is there, that yes, one of the reasons for PIH, one of the factors which is responsible for abnormal vascular remodeling is immunological factor. Right? Number 2 is genetic factor. How is this theory supported? This theory is supported because we have seen that females with family history of preeclampsia in their mother or sister have increased risk of preeclampsia in their pregnancies, number 1. Number 2, a female with previous history of preeclampsia in their earlier pregnancies have 7 times more chances of preeclampsia in their next pregnancy. Now, the most important gene which leads to preeclampsia is chromosome number 13. Why? Because chromosome number 13 encodes for SFLT1. And this is the reason why in trisomy 13 patients, there are increased chances of PIH. Please remember that for PIH, the gene which is responsible is chromosome number 13. But for HELP syndrome, the chromosome which is responsible is chromosome number 12. So for HELP syndrome, it's chromosome number 12. For PIH, it is chromosome number 13. Right? Then environmental factors. Decreased calcium intake, high BMI and IVF, especially with donor eggs. Right? These are again environmental factors which can have a high risk for PIH. Now, based on this, now we can make a list of all the risk factors for preeclampsia or PIH. Right? Now, when we are talking about preeclampsia or PIH, risk factors, as I told you, this is very, very important. And for all the risk factors, I want you to divide them into the way I have divided. Factors where there is increased risk and factors which have high risk. Now, you're going to say, ma'am, what does that mean? Factors which have increased risk and high risk. These factors which are coming under high risk, these are the conditions where I can prevent PIH by giving them aspirin. Right? So this I'm going to tell you a little later, but first understand that you have to write it in the same manner as I am telling you. So based on our previous discussion, the risk factors for PIH are nulliparous females or primigravida females, new paternity, long interval of pregnancy more than equal to 10 years if earlier pregnancy was normotensive, and short interpregnancy interval if earlier pregnancy was hypertensive pregnancy. So long interpregnancy interval if earlier pregnancy was a normotensive pregnancy, and short interval if earlier pregnancy was a hypertensive pregnancy. Then molar pregnancy. If there is history of preeclampsia in mother or sister, or in women herself was a small for gestational age fetus. Then obese females, pregnancy due to IVF, extremes of age. That means if pregnancy is happening at less than 18 years or more than 40 years, use of barrier contraception before pregnancy, and hydrops fetalis. So these are all those factors which come under increased risk. The other risk factors which come under high risk are if there is a female has previous history of preeclampsia, or if it is a case of multifetal pregnancy. In multifetal pregnancy, there will be increased exposure to paternal antigens. Then diabetic females, females with kidney disease, females with immune related disorders like APLA. Already it is an immune related disorder, so there will be increased chances of immune related problems related to vascular remodeling. Then a female with chronic hypertension. So these are high risk factors. High risk factors are if there was previous history of preeclampsia, or female herself has chronic hypertension, if she has diabetes, if she has kidney disease, if she has APLA, that is immune related disease, and if it is a twin pregnancy. In these 6 conditions which come under high risk conditions, ACOG says that if any of this risk factor is present, right, if any one or more than one risk factor is present, then you have to give them low dose aspirin to prevent PIH. This means that in all twin pregnancies, you are going to start them with low dose aspirin. In all diabetic females, that you are going to start them with low dose aspirin. In all females with kidney disease, when they become pregnant, you are going to start them with low dose aspirin. And what dose are you going to give? 75 to 150 milligrams. Although the guideline says 80 milligrams, but that is not available. So we are going to give 75 to 150 milligrams. When are you going to start? You are going to start it between 12 to 16 weeks of pregnancy, definitely before 16 weeks. Ideally, you should start at 12 weeks, but definitely before 16 weeks, you should start. And when should you stop? At 36 weeks of pregnancy, you should stop. What is this aspirin going to do? This aspirin is going to decrease the chances of PIH, right? Now, what the New Williams says, this is something which you have to note. New Williams says that yes, if any of these 6 risk factors is present, you have to give aspirin. But then it says that if any or 2 or more than 2 of the following 6 risk factors are present, then also you may give aspirin. Are you understanding? So, ACOG has said that if out of these 6, any one is present, you have to give aspirin. Now, New Williams says that yes, you have to give aspirin if any one of those was present. But if any 2 or more than 2 of the following 6 are present, then you may give aspirin. And what are they? Nulliparous female, age more than equal to 35 years, obese female, prior history of low birth weight or IUGR, family history of preeclampsia, or vulnerable socio-demographic factors. Right? So if any 2 or more than 2 of these are present, then you may start aspirin in them also. Clear to all of you? Okay. So, what all have got a proven role to prevent PIH? The most important drug which can prevent PIH is aspirin, and that is proven, right? Then number 2 is calcium supplementation. Remember, calcium supplementation has a proven role to decrease the chances of PIH only if pregnant females' calcium levels are low. If it was decreased calcium level, as you know, I told you, decreased calcium intake is one of the risk factors for PIH. So, if I know that the patient's calcium levels are less, and if I give her calcium, I can prevent her from having PIH. But that doesn't mean a female whose calcium levels are normal, and if I give her calcium, I can prevent PIH. No, that's not the case. Number 3, if the female was obese, prior to pregnancy, then weight loss, so you can suggest weight loss to such a female before she conceives to prevent PIH, right? But the best drug is aspirin. Remember that there is no role of low salt diet, there is no role of absolute bed rest, no role of antioxidants, no role of fish oils. They do not have any proven role to prevent PIH. Right? Now, are there any tests which you can do to predict PIH? Yes, there are certain tests which you can do theoretically to say that your patient is going to have PIH, and theoretically if there is increased SFLT1, increased serum endoglin levels, or decreased vascular endothelial growth factor or placental growth factor, they have a theoretical role for diagnosing early onset preeclampsia, and they also have a theoretical role for differentiating between mild and severe disease. Out of all these, best is the ratio of SFLT1 is to placental growth factor, right? Then uterine artery Doppler also has a role for predicting PIH. Now, everything about uterine artery Doppler I have told you in OBS radio integration. I am not going to repeat it here. Please remember that for predicting that a female may have PIH, the role is of uterine artery Doppler. But for fetal surveillance in patients of PIH or for uteroplacental insufficiency, the Doppler which you do is umbilical artery Doppler. Right? The predictors which are no longer used are rollover test, angiotensin 2 challenge test, and serum uric acid levels. It is no longer used. In pregnant females with PIH, there is increased sensitivity to angiotensin 2, and that binds to angiotensin 1 receptor, the angiotensin 2, and it leads to PIH and increased vascular injury. That is the role of angiotensin 2 in leading to PIH. So it was seen that angiotensin 2 challenge test could be used as a predictor for PIH, but it is no longer used. Serum uric acid levels is no longer used. Rollover test is no longer used for predicting PIH. Also, these tests which I told you, they just have a theoretical role. Practically, none of these tests is used to predict PIH. Now, before I end this session, just one thing which I want to tell you. One very important thing which Williams has said is why convulsions happens in patient of eclampsia. See, normally there is a cerebral autoregulation which helps to maintain cerebral blood flow despite the alterations which are happening in cerebral perfusion pressure. Right? Now, if you remember that what a fetus does, whenever a fetus receives less blood, it sends more blood to its brain. Right? Now, a similar thing happens in all of us also, that whenever we are having any crisis, during that moment of crisis, our brain gets more blood. That is, there is hyperperfusion. But this hyperperfusion in itself can injure the brain. Right? So that is why we have autoregulatory methods which help to maintain the amount of blood which is going into the brain. Now, in females with preeclampsia, this autoregulation is lost. So what is going to happen in a female with severe preeclampsia? In a female with severe preeclampsia, there will be segmental vasoconstriction. At places, there is going to be vasospasm because of all the vasoconstrictors which have increased in the mother. Right? And that is going to lead to ischemia in the brain. Number 2, there is going to be cerebral hyperperfusion as well. Right? As I told you, whenever there is crisis, whenever there is stress, our brain is also going to receive more blood. And now this patient of preeclampsia, the autoregulatory mechanisms are not working in her. Right? So because the autoregulatory mechanism is not working, so there can be hyperperfusion, and because of this hyperperfusion and endothelial cell injury, there will be leaking of fluid, which is going to lead to perivascular edema in the brain also. Right? So 2 things are happening in the brain. At places, there is going to be vasospasm, and that because of that vasospasm, there is going to be ischemia. Right? And number 2, there is going to be cerebral hyperperfusion and endothelial cell injury, because of which there is going to be perivascular edema. Both these things lead to convulsions. Both these are the cause of convulsion in a patient of eclampsia. So convulsions are happening not just because of vasospasm. Convulsion is also happening because of the perivascular edema which is happening due to cerebral hyperperfusion. Right? So this is all what you needed to know on PIH part 1. Now we are going to talk about management of PIH in video 2. See you in the next video.